This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Alara, a neurosurgery research fellow. Today we're looking at a fascinating new study from the University of Eastern Finland and Kuopio University Hospital, published in Acta Neurochirurgica. The paper is titled Reduced Risk of Shunt Revision with Adjustable Valves, a population-based cohort study over 3 decades.
It's a pleasure to have you here, Alara. This is a topic that hits home for anyone who spends time in a hydrocephalus clinic. We're talking about idiopathic normal pressure hydrocephalus, INPH. It's that classic triad: gait disturbance, urinary incontinence, and cognitive decline, all paired with ventriculomegaly.
Exactly. And as we know, the only effective treatment we have right now is cerebrospinal fluid shunting. But the Achilles heel of shunt surgery has always been the revision rate. Shunts fail, they clog, they overdrain, or they underdrain. This study really dives into how the technology of the valve itself, fixed versus adjustable, impacts those revision rates over a very long timeline.
Right. Now, for the residents listening, let's set the stage. In the old days, which, according to this study, includes the 90s and early 2000s, we primarily used fixed pressure valves. If the patient didn't improve, or if they developed a subdural hematoma from overdrainage, your only option was to go back to the OR and swap the valve for a different pressure setting.
Which is exactly what this study quantifies. They looked at a massive cohort from Kuopio, 1,220 patients evaluated, with 809 eventually receiving a ventriculoperitoneal shunt, or VPS, for INPH. They followed these patients from 1991 all the way to 2023. That's 32 years of data.
That longitudinal aspect is key. What were the specific groups they compared?
They split them into 2 main cohorts based on the era and valve type. We have the fixed pressure group, which consisted of 243 patients treated between 1991 and 2012. Then we have the adjustable valve group, which had 566 patients treated between 2008 and 2023.
So there's a bit of overlap in the middle years, but generally it tracks the transition in neurosurgical practice toward adjustable technology. What did the primary outcome show?
The results were quite striking. The overall revision rate for the fixed pressure group was 30%. For the adjustable valve group, it dropped to just 14%. That's a statistically significant difference with a p-value of less than 0.001.
A 50% reduction in the risk of revision. That's huge for the patient, obviously, but also for the healthcare system. Every revision is a new hospital admission, a new risk of infection, and more OR time. Did they look at multiple revisions? You know, those frequent flyer patients who seem to need 3 or 4 adjustments.
They did. The incidence of multiple revisions was also lower in the adjustable group, 27% versus 32%. While the gap there is smaller, it still favored the adjustable valve significantly.
Let's talk about the why. When a fixed pressure valve fails, why is it usually happening compared to the adjustable ones?
This was the most interesting part of the results section for me. In the fixed pressure group, the most common cause for revision was shunt underdrainage, accounting for 25% of their revisions. Essentially, the pressure was too high, the patient wasn't improving, and the only way to fix it was surgery.
And in the adjustable group?
In the adjustable group, underdrainage as a cause for surgery virtually disappeared because, as you mentioned, we can just adjust the setting in the office with a magnetic programmer. Instead, the most common cause for revision in the adjustable group was actually peritoneal catheter malposition, which accounted for 44% of their revisions.
That makes sense. We've solved the pressure setting problem with technology, so the remaining reasons for surgery are the purely mechanical ones. The tube migrated, it got kinked, or there's a distal obstruction. It shifts the burden of failure from the valve mechanism to the surgical anatomy.
Exactly. The study notes that adjustable shunt valves have specifically decreased the need for revision surgeries due to both underdrainage and overdrainage. If a patient with an adjustable valve shows signs of overdrainage, like postural headaches or small subdural collections, we dial up the resistance, no incisions necessary.
I want to play devil's advocate for a second for the residents. Adjustable valves are significantly more expensive than fixed pressure ones. Some hospital administrators might look at the upfront cost and hesitate. What does this study say to that?
The authors address that directly. While the unit price of an adjustable valve is higher, the cost of a single revision surgery, including the hospital stay, the surgeon's fees, the OR materials, and the risk of complications, far outweighs that initial price difference. By cutting the revision rate from 30% to 14%, the adjustable valves likely pay for themselves many times over.
Not to mention the patient's quality of life. For an 80-year-old INPH patient, an extra general anesthetic and a week in the hospital is a major physiological stressor. If we can avoid that with a 30-second magnetic adjustment in the clinic, it's a no-brainer.
And the study also touched on the diagnosis. They mentioned that even with adjustable valves, we still rely on clinical suspicion and the CSF tap test. They had a very rigorous protocol at Cupio, which I think adds a lot of weight to these findings. This wasn't just a random mix of patients. These were 809 confirmed INPH cases.
It's also worth noting the overdrainage stats. Did they see a significant drop there too?
They did. In the paper, they highlight that the ability to fine-tune the opening pressure allows for a much more physiologic approach to shunting. We can start at a higher pressure to avoid sudden intracranial hypotension and slowly work our way down until the gait improves. In the fixed valve era, you are essentially making a one-time bet on a specific pressure setting.
Now, let's look at the limitations. This is a retrospective study over 30 years. Surgery in 1991 wasn't the same as surgery in 2023. Did they account for the learning curve or changes in surgical technique?
That's always the challenge with these long-term cohort studies. The fixed pressure group is older, so there's a chronological bias. Techniques for distal catheter placement have improved, imaging is better, and perioperative care has advanced. However, the authors argue that because the primary reason for the revision drop was the elimination of pressure-related surgeries, the valve technology itself is the most likely driver of the improvement, rather than just better suturing or faster OR times.
That's a fair point. If the difference was just infection rates, you could credit modern sterile technique. But when the difference is we don't have to go back in to change the pressure, that's clearly a hardware advantage.
Another interesting data point, 430 of the 809 patients had passed away by the end of the study. This really emphasizes that INPH is a disease of the elderly, and our goal is to maximize their remaining good years. If we spend half of those years revising a shunt, we failed the patient.
Well said. So what's the take-home message for a resident who is in the OR tomorrow for a VPS?
The take-home is that the data now strongly supports adjustable valves as the standard of care for INPH to minimize long-term surgical morbidity. The revision rate is less than half of what it used to be. Also, keep an eye on your distal catheter. Since valve failures are dropping, the peritoneal end is now where your highest risk of mechanical failure lies.
And for the practicing surgeons, it's a reminder that even though the technology is better, we still need to be vigilant about long-term follow-up. A revision rate of 14% is better than 30%, but it's not zero.
Exactly. And always document those valve settings. There's nothing worse than a patient showing up in the ER with a headache and no one knows what their shunt is set to.
A classic neurosurgery headache indeed. Well, Alara, this was a great breakdown of the Acta et al. Paper. It's a solid piece of evidence for something many of us felt was true anecdotally, but it's vital to have the population-based numbers to back it up.
Agreed. It's a great example of how longitudinal registries can answer questions that a short-term trial just can't.
Absolutely. Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.
Keep learning, and we'll see you in the OR.